Hello, everyone, and greetings from St. Louis, Missouri, and the home of the Missouri Institute of Mental Health. My name is Tom Pancello with MIMH. Thanks for taking the time to view today's program. We're joined by Bruce Horowitz, and I'll introduce him to you in just a moment. But for those of you joining us online, if you'd like to ask questions at any time during the presentation, please click on the Questions for Speaker link underneath the video window. That'll send us an email with your question in it, and we'll feed those to the speaker on your behalf. If you'd like CEUs for today's program, there's also a link to apply for CEUs. CEUs are only $10 for this program. We'll keep that link active after the program and send it to you in email as well. Also, Bruce's slides are available as a link there. If you want to click those into a pop-up window, if you're following audio only, or even if you are following the video and like to flip through the slides on your own, you can do that. That's a PDF file for you as well. And because Bruce is also one of our presenters at the Department of Mental Health Spring Training Institute, we've provided a link to the registration for that program as well, because I know that his presentation today will get you all excited about registering for that program, even if you're not in Missouri currently. And so today's program is called A Public Health Approach to Promoting Mental Health and Preventing Mental Illness. And Bruce Horowitz is a research assistant professor here at the Missouri Institute of Mental Health, which is part of the University of Missouri School of Medicine. Prior to joining our faculty in 2008, Dr. Horowitz directed community mental health programs for the University of Missouri. His research interests focus on community-based approaches to prevention and integration of substance abuse prevention into general medical care. And Bruce, thanks for joining us. The floor is yours.
Thank you for having me. And thank you out there in webinar land for joining me. It's my pleasure to talk about this project that I've been working on with colleagues now for actually several years, and I'll give you a little bit more about the history of how this project got started. But as you can see from the first slide here, the project's called Show Me Bright Futures. And it's an adaptation of a national program called Bright Futures to Missouri. Underneath my name here, I've also listed Dr. Ed Morris, who's a colleague of mine and who is actually the day-to-day project coordinator. So let me go to the next slide, except it's not changing. Huh? Okay.
Go ahead. Let's change that.
No? Oh, there you go. All right. All right. So, objectives for today, short and sweet. Learn the key issues that require what we call a paradigm shift to a public health model for mental health. Our current model of care in mental health is very much focused on acute care. The second objective is to briefly just learn the history and key features of the national Bright Futures and the state version of that, Show Me Bright Futures. Learn the basic components of the public health model and learn how we're applying that in the Show Me Bright Futures to promoting mental health and preventing mental illness. So, to deal with that first learning objective, these are just a few key facts that tell you, give you an idea of the magnitude of the problem. 20% of children suffer from mental health problems. And when I say suffer from a mental health problem, I'm talking about suffering to the extent that it interferes with their functioning in some sort of observable way. That translates in Missouri to 190,000 children, again, who experience problems severe enough to impair functioning. Less than 50% of those children receive adequate services. And this is something, those facts are lesser known. The last bullet on this slide is something I think people are a little bit more aware of, because teenage suicide gets a lot of press attention. So all of this takes place in the context of a society that's really in transition in many ways that I think concern a lot of us in mental health service delivery or in healthcare. Changing family structures. We know that there are lots of variations now on the traditional family. Populations are mobile. People move around quite a bit. Health disparities. We know that people have unequal access to health care and unequal outcomes depending on a lot of variables, but socioeconomic status is foremost among them. Our communities and neighborhoods are deteriorating both physically and I think structurally. The infrastructure for our communities is deteriorating. Substance abuse is reaching very alarming proportions. And all this takes place in the context of something we know very well here at MIMH, increasing costs and decreasing resources. Any of you out there who work in the public sector especially know that. But the only place that is immune from that is the banking industry, apparently. Laugh line. Okay, so that is a very simple way of laying the foundation to make the claim that we really need a new paradigm. We have to move away from our focus on acute care and move toward prevention. We will, and this comes from my community mental health background as an administrator of a service delivery system. There's never going to be enough dollars to meet the need. We always felt like, as good as our organization was, behavioral health services for the university, we always felt like we were putting our fingers in the dike. So we need to engage communities to implement a public health model. We have to move toward a prevention orientation and plan for healthy physical, social, and emotional development of kids. So why prevention? Well, one picture is worth 1,000 words. So here are some slides of neuronal development from birth through age 14. So you can see what the brain looks like, or at least a part of a brain looks like at birth. There's very few neurons there, pretty primitive. And by 6 years old, you can see that there's been extensive development. Now you see by 14 it's actually starting, there's been some pruning that's been going on, and I think that's a neurological term, so it's actually pared back a little bit, but you can see that the critical time for neuronal development is between birth and 6 years old. So that is a critical time in which to intervene with kids. Same thing. These are MRIs. You see the same thing. You see a brain scan at 5 days, 2 months, 1 year, and 28 years. And you actually see the same sort of thing where there's a lot of growth and a lot of development, and then by 28, we're starting to dement. Yeah. 60-year-old brains. Really depressing. Yeah. So, okay, why community? Why is that so important? Well, I'm going to share with you some results from an unlikely source, the Minneapolis Federal Reserve, who actually approached this whole question from an economic perspective. And I find that especially fascinating because it really puts the discussion on a different kind of framework that communities can really relate to. So this first slide shows the educational characteristics of the labor force as it will evolve, as it is evolving from 1980 to 2020. And you can see that back in 1980, high school education or less was pretty much okay. By 2020, there's going to be a high demand for highly educated people. So we really need to be able to make sure that we have an educated workforce. So the Federal Reserve looked at a variety of studies that examine the effects, the long-term effects of early child interventions. So in the early 60s, they looked at, there was a study that looked at 123 kids from low-income families in Ypsilanti, Michigan. Remember where the three Christs of Ypsilanti? Where that's the same place. Children were randomly selected to attend the Perry preschool program or a control group. The Perry preschool program was very high quality, well-trained teachers, daily classroom sessions, weekly home visits, and they tracked the participants in the control group through age 40. There's very few studies that look at this kind of long-term outcome, but this is following people over 35, 37 years. Pretty impressive. So, the results, educational effects, you can see pretty easily. The control group is in yellow, the program group is in blue, and you can see that the program group had substantially, significantly higher achievement in education. Economic effects, same thing. You can see that the program group, the group that attended the preschool program, had significantly better financial outcomes, earned a lot more money, which is a benefit to them and also to society. This is a slide on arrests, and I haven't quite figured out this slide in one way. It's not clear to me why there should be so many people in the control group who had arrests, but nevertheless, you still see the same effect, that the program group is doing a lot better. And that's the same slide in average number of months served in prison. And here's the overall, here's a slide that depicts the cost benefit. So everything to the right of zero is a benefit, everything to the left of zero is a cost. So you can see that the benefits far outweigh the costs. And interestingly, the benefits are both for the participant and for the public. So, return on investment, the cost-benefit ratio is 17 to 1. Who wouldn't take that kind of return on investment today? Annual rate of return is 18%. What is it now? Something on the negative side of zero? Public rate of return is 16%. In other words, the return on public dollars that were invested. There have been, the Federal Reserve study looked at several other similar studies and found the same thing. The cost, the return on investment was somewhat different, but still a very substantial return on investment. Lessons learned: invest in quality. The Perry program was expensive, but as you saw from the previous slides, the return on investment was huge. Reach at-risk population. You really want to do a community outreach and get to the population that is most at risk for bad outcomes. And teach cognitive and non-cognitive skills. So now I'm going to move on from that as kind of a background to talk about what the community health approach is. And this is moving more into talking about what the public health model is. Right now, our service system is very much focused on that 5%. There was a time in my 30 years of working in mental health that we were able to do some of that stuff, that 5 to 15%. But more and more, especially public mental health funding, is focused on that top 5%. And really, even commercial retail insurance is focused on people. You have to be sick in order to get care. So the biggest part of our population is down here in this 75% that don't have the obvious mental health problems, but that will potentially develop those problems if we don't do something about them. So you can see our service system is a little bit backward. So, primer on public health, 3 basic functions for public health. One is surveillance and assessment. Surveillance is monitoring various indicators to identify when and if you have a problem and where you have that problem. It also includes assessment and commonly needs assessments and finding out what are the areas of need for the community. Policy planning and development, which flows, and this is kind of the order in which they go. You do surveillance and assessment. From that data, you do policy planning and development. Based on your indicators, what needs to be different? And how do you make things better? And in a public health model, you're not so much focused on individuals as you are on things that affect the entire population, like the environment, like your priorities in service, prevention, early intervention, and assurance. As with anything, it's all talk unless you have a way of ensuring that you're doing what you said you were doing, and you're measuring the effect of what you're doing to make sure that it is effective. So that's what that looks like, just in a graphic, and it is a continuous circular process. In other words, it just keeps on repeating itself, and hopefully in a process of continuous improvement. So this is a remarkable shift in focus for people in mental health. People in the health sector in the general health sector are a little bit more accustomed to dealing with these concepts, but for us it's major. It's a shift in focus from proximal causes to root causes. So if we see a bad outcome with a child or with a family, instead of looking at, say, the abuse that might have gone on in the home that would precipitate some sort of mental health crisis, we look at factors that preceded that. What led up to that abuse? A common strategy in applying this model is to ask the question why repeatedly until you get back to the earliest determinants of a problem. So if the proximal cause is, say, abuse, then you ask the question, well, why was abuse going on in that home? And then you might find out, well, those parents were abused, or they didn't learn good skills. You might go back further than that and ask that question, well, why did that happen? Well, maybe it was because of socioeconomic conditions that family was suggested to. I've heard it said that you have to ask that question why at least 5 times before you can get to the cause for why you had that acute event. And so as a direct care provider, we need to do something to help that child right away. But from a public health perspective, you need to push the question back to the root cause. So this is a real difficult thing for us to do, especially, as we noted earlier, during a time of dwindling resources when you really don't have enough to do what you're doing to take care of that acute care population. So how do you turn your resources to prevention? Well, one of the things that we suggest is that how can you not? we're not taking care of the needs. We have to do something to prevent those situations from happening in the first place. Now I'm going to shift and talk a little bit about Bright Futures. Bright Futures is a national initiative that originally developed with participation of these agencies. The beginnings, excuse me, let me have a sip of water here. I'm going to pause and just ask Tom if there are any questions at this point.
None so far.
Okay, all right. In 1990, HRSA and HCFA launched Bright Futures to improve health services for kids. And the emphasis was on promotion and prevention. Bright Futures was enormously innovative when it was developed. It was a single standard of care. It was based on developmental stages, and it was comprehensive. It wasn't just dealing with kids' illnesses. It was looking at their psychosocial needs within their family and their community context. A revolution, really, and still a revolutionary concept if you think about child care, health care today. Bright Futures is, in some ways, is somewhat amorphous. It's many things. If you read the Bright Futures material, you'll see things about vision, philosophy. There's also a very explicit, an extensive set of guidelines with tools for physicians and pediatricians and families to use. And it's a developmental approach that looks at kids from birth through 21. The centerpiece for Bright Futures are these guidelines that I talked about, these very specific manuals that they provide. Again, designed to provide a single standard of care, and it, again, a kind of a paradigm shift away from a focus on illness and more toward looking at a child in his family and community context. The development of those standards for Bright Futures was broadly interdisciplinary, and this is a listing of some of the organizations that were involved in the creation of those standards. Relevant to this audience in particular, there is a specific manual for mental health with an emphasis on promotion of mental health, prevention and early recognition, helping providers learn what the earliest signs of mental health and family problems are. And it looks at developmental issues by age, and that's critically important because behavior that is inappropriate at one age for a child can be appropriate at another age. And so it's important to understand what the expectations are based on developmental age. And this is just a picture of what the Bright Futures materials look like. There's some modules on nutrition, physical activity. That's just a sampling. So I had to put this picture in because it reminded me of my daughter when she was that age. Everybody's got to have a vision. This is a great one. That children deserve to be healthy, to experience joy, have self-esteem, have a caring family, and to believe that you can succeed. Core concepts in Bright Futures, again, we're talking about the national model that prevention works, families matter, and health is everyone's business. I think we tend to think of health as being the province of healthcare providers, and this is another aspect of the paradigm shift. Health is really a community matter. Prevention works. It works in all the ways that we're familiar with, like safety seats and fluoridation and immunizations. the idea that prevention can work with mental health is a new concept, and one that we have difficulty wrapping our brain around. Families matter. Families are critically important in mental health promotion and prevention. Seeing families as partners, caregivers, teachers, and resources. Community partners, once again, this is not something that is restricted just to your pediatrician or your public health department or your mental health agency. This really extends across the whole range of people who are involved in working with children, with, I would note in particular, schools. So what is Show Me Bright Futures? That's the National Bright Futures. What is Show Me Bright Futures? We've been meeting actually since 2005. This project, this particular project that I'm talking about here today, is only a couple of years old, but a state planning team has been meeting since 2005. There are a number of departments and organizations that have come together to define common needs and purposes. So, and you'd be amazed at how challenging that is. What do DESE, the Department of Elementary and Secondary Education, what does that group have in common with the Department of Health? Well, one example is that healthy kids can achieve more in school. So DESE wants kids to achieve in school, but they can't achieve very much if they aren't coming to school healthy and ready to learn. Our concept of who we are and what we're doing evolved from a focus on training. Began with training maternal, it began with training school nurses on how to use the mental health, the Bright Futures mental health module. And it evolved to the community focus that I'm talking about now. Here's a list of the Show Me Bright Futures state planning team members, and you can see that it's well represented by a real cross-section of state agencies, Department of Mental Health, DHSS, DESE, Social Services, Missouri School Boards, Head Start, Children's Trust Fund, which is an important partner for us in all of this, several other groups. Our objectives. To build teams of community stakeholders who are committed to collaboration, foster the ability to collect and analyze data, to help those community groups do that, and to help them develop a strategic plan that focuses in part on mental health promotion. So what do we do? And now we're talking specifically about this project and this grant, which is, by the way, funded by the Missouri Foundation for Health, and with some matching funds from Heartland Institute with SLU, St. Louis University, and also with some matching funds from the Department of Mental Health. We provide training and technical assistance for communities to implement the public health model, as we talked about, to develop collaborative relationships. We disseminate the Bright Futures materials. We work with them to develop indicators for that surveillance component. We help them with strategic planning, project design and implementation. One of the requirements of this project is that the communities we work with develop and implement 2 evidence-based prevention projects during the course of the 3 years of the grant. We work closely with the Community-Based Child Abuse Prevention Initiative, which is grants to communities provided by the Children's Trust Fund. We partnered with them in the early stage of this project because they have been doing similar work with communities in the area of prevention of child abuse. And so we've really worked with them to build on the infrastructure that they've had with several communities in Missouri. I'll talk a little bit about those in a minute. This is a 3-year commitment. Not quite long enough, I think, to really get some things done, but long enough to get something going and hopefully get some uptake. There's an ability for the state, for the communities to communicate with the state teams. We have people who can, in theory, solve some problems at the state level. Not that we have any, but if there are problems, we might be able to help resolve them. We also provide the communities with some modest funding to support the project and to support a coordinator and also to implement their projects. What do communities have to provide? They have to provide buy-in. That's was fundamental, and that was really the basis for how we selected communities. We needed some infrastructure and we needed some buy-in. A commitment to health prevention and promotion, to work together. That is surprisingly difficult to do for a lot of communities. But the ones we work with, I think, have a track record of doing that. And a commitment to doing systematic evidence-based decision-making, which is terribly hard to do. Time and effort takes a lot of time, and a willingness to consider new ways of doing things. A lot of communities get together and work together to treat individual families or kids. It's harder for them to get together, to work together, to do this kind of community development and prevention work. Any questions yet?
From the outside here. Reminder to anybody that does have questions, please use the questions for speaker link underneath the video window. We'll take them at any time during the presentation.
So, phases of implementation for the project. The first phase was to select the communities, which, by the way, are Moberly, Joplin, and Rolla. And each of those communities has either has or has had one of those Children's Trust Fund grants, and that preceded our project. And one of the advantages for us in selecting those communities is that they already have some experience coming together and working together as a team successfully to write a grant and execute a grant. So we were looking for communities that weren't kind of at ground zero, but had already had a little bit of experience working together as a team.
That worked. We got a couple of questions.
Okay. All right.
Could you discuss the module school nurses were using for Missouri Show Me Bright Futures, the content of that module? That's the first question.
The mental health module basically describes the emotional and cognitive development for kids, so that people will know what to expect from kids' behavior at various stages. And then also the early warning signs of various kinds of more typical mental illnesses for kids, like ADHD and depression. So, and school nurses are in a really key position. They're really gatekeepers for kids in schools, because that's where kids go to deal with their problems. So it was important for nurses to get that kind of information. So that's a general description. Okay. By the way, if you if you Google Bright Futures, you can get to all that content. It is available online. Okay, second question.
Second question, could you talk more about the bank community motivation for the first study program you discussed? How can we do this?
Can you repeat that question?
Can you talk more about the bank/community motivation for the first study or program you discussed? How can we do this?
I can't tell you exactly how that Perry School project got started. I assume that they got a grant from somebody to do that, because that was a major initiative, but I can't tell you how it got started. The Federal Reserve study was opportunistic in the sense that it looked at, the Federal Reserve didn't do the Perry School intervention. They simply collected research that was out there. So it wasn't the bank that did the study, they just collected data. Hope that answers your question. If not, shoot us a follow-up question. So, farm teams, meet regularly. That is really, can't tell you how important that is, to get together and meet on a regular basis, on a scheduled basis, and sit across the table from each other and build relationships. One of the things that we do is we provide 2 training academies a year where we bring everybody together to Columbia and provide some intensive training on topics that are relevant to this project. We ask each community to develop a systematic community assessment process. We'll talk a little bit more about that in a minute. Use that data to identify needs and to develop a strategic plan to tell us what they're, based on that strategic plan, what kinds of training and consultation needs they have, and to design and implement, as I said earlier, 2 focused prevention projects with measurable outcomes. And I emphasize that last one because communities get excited and they really sometimes choose projects that are much more than they can accomplish. And so we really have been working with them carefully to narrow their focus and choose projects which can produce a measurable outcome in a short period of time. We're not going to change those big indicators like the number of kids who complete high school. That takes years and years to accomplish. But they can achieve smaller outcomes which give them the experience of success, which is critical to moving on with this. As I said earlier, we had 3 pilot communities. Rolla, Lisa Keene is the project coordinator in that area. The project supports some of her time. She's actually a public health nurse who's doing this part-time. In Moberly, it's Shelley Freeman, who works with the community partnership there, and Linda Sievers in Joplin. These are some of the types of groups that you see in the teams that they have formed to implement this project. So, a list of some of the activities that we have had. We had an initial training academy in 2009. We also had a community information management orientation in the fall of 2009. I'm going to talk a little bit more about Kim in a minute. That's a core part of the work that we do. We just completed not too long ago another training academy. And again, not too long ago, an update on Kim, which I'm going to talk about here. One of the things that we are doing is trying to develop, helping the teams to develop their partnerships. And we are working with DHSS, the Department of Health and Senior Services, that has a division of maternal child health. And each region in the state has a maternal child health nurse who is an expert in the public health model, and we have partnered that nurse with each of these communities. So there's 3 nurses who are working with these teams, and they're the ones who are really the kind of the local experts for these communities in the public health model. it is very, very difficult to stray from a public health model back to kind of the usual way of thinking about services. So the nurse is somebody that kind of helps them keep on track. This is this slide shows you the KIM website. KIM is stands for Community Issues Management. It is a project that was developed by the University of Missouri. And what it does is allows our communities, it gives them a resource to access incredible amounts of data and to organize that data, to map that data using geographical information systems, and to put that together to define the issues in the community that way they want to work on. So this slide just shows you the kind of the features of KIM. Includes a library with issues notebooks where you develop a notebook for each particular issue that you want to address. You can create maps. I don't know how many of you are familiar with graphical information systems or geographical information systems, but you can look at, let's say you want to look at the number of farmers markets in a particular region. You can plot that on a map and see where they are in relationship to your neighborhoods, parks, schools. Any measure that you can think of can, at least in theory, be mapped. And people like maps, and it helps them to kind of make sense of the space that we live in. You can generate reports. You can organize the data. KIM allows you to organize the data in a variety of different ways to generate reports. It also provides us a space for the sites to communicate with each other, and there's various other tools within KIM. So this really relates to this portion of the public health model. We're trying to give communities the tools that they need to do surveillance and assessment. And again, helping them to use data. Chris Fulcher, the fellow who created KIM, likes to say data everywhere, but not a byte, to B-Y-T-E, to think. We are flush with data. We have data of all kinds, just incredible. We're overwhelmed with data, but it's hard for us to organize it and think about it and use it. And KIM is the real interesting and useful aspect of KIM is that it allows us to organize information in ways that can be used for decision making. So it's really a decision support tool more than anything else. So current status, focusing on team and network development. That is an ongoing process. We envisioned initially that we could farm these teams and move forward. Well, some form of team was developed initially, but it wasn't nearly what we hoped it would be. We really want to be all-inclusive. We want to include schools, government, the faith community. It's hard to get all those people to come to the table. We're with that KIM training, the communities are learning how to do assessment and surveillance. We have what we call travel teams and home teams, and the travel team is the one that comes to the academies and learns how to use, and all the trainings, and learns how to use these tools, and they take that stuff back to the home team and hopefully transmit that to them. Right now, they are in the process of finalizing their plans for their first projects. And we have some expectations for them to start to collect data later this year. And they're starting to work on strategic planning. In theory, strategic planning would come before you do your project, in reality, in the reality of working in communities, strategic planning is a really kind of a developmental process. Just as we have to pay attention to the developmental stages of kids when we evaluate their behavior, we also learn that we have to pay attention to the developmental stages of communities and kind of work with them where they're at. Team examples, Rala is looking at teen pregnancy, school dropout, juvenile substance abuse. Moberly is looking at increasing parent and provider knowledge. Joplin is working on addressing the impact of witnessing trauma or abuse. These were some of the results of the assessments, community assessments that our communities are doing. Rala is in Phelps County. They've identified those issues as being core problems. They looked at their programs in their communities that are addressing some of those issues. That's kind of a resource assessment. And these are the gaps that Rala identified. They have a program that's successful. It's called Girl Power. It's evidence-based. It has some evidence, I should say, to support its efficacy. But it was for girls, and it wasn't for boys. And boys had a need for that kind of program as well. It was also initially targeted at high-risk kids. And that's good, but it's not prevention. It's a form of prevention. It's a secondary prevention, I guess you'd call it. But if you really want to do the kinds of things we're talking about, you make this program available to everybody. Randolph County. This is some of the data that Randolph County was looking at, and I won't read through that, but these are just some of the things that that team was looking at. They went through what we talked about earlier, a root cause analysis, and that process led them to the conclusion that child care providers, teachers, and parents didn't have enough information about mental illness. And so their project is going to focus on educating that group of people. And again, you can see the effect of the public health model there. They're not looking at individual kids. They're not looking at even a high-risk group of kids. They're doing education for an entire population. Jasper County is a work in progress and still kind of focusing on what their project is going to be. They had a little bit of a delay because there was a change in leadership. And there's some data some of the data that they are looking at to determine what their priorities are going to be. They've identified the elephant in the room as parental issues, chaos in the home, witnessing of abuse, and lack of resources. Another component of Bright Futures, or Show Me Bright Futures, is evaluation. That's something that Missouri Foundation for Health requires of all its grantees, is to do extensive evaluation. And so these are some of the aspects of our evaluation program. And we just actually hired an evaluation coordinator who is going to help us put this whole plan together. So, as I said earlier, this project is funded by the Missouri Foundation for Health. Those of you who are not familiar with it, it's a philanthropic organization whose vision is very simply to improve the health of the people we serve. So if you want some more information, you can contact me. Here's my contact information. email and telephone number, or Dr. Ed Morris. So now, let's go back and see if there's any questions.
And again, we invite people to submit questions using the question for speaker link underneath the video window. Are there questions in the room here with us? Mary?
Bruce, I saw a lot of similarities there with the substance abuse prevention model, the strategic prevention framework. They go through assessment and building capacity, doing a strategic plan, evaluation, finding programs to implement. And we know that later on in the treatment side, there's co-occurring substance abuse and mental health issues. Has anybody thought about at the prevention public health model, since substance abuse is moving towards public health, and it sounds like
bringing those two things together? Yeah. What a concept.
Yeah, and Randolph County was one of our SMBF grantees, and I think it's the same coalition. So
yeah, that's a great comment, Mary, and there has been some thought. We actually have talked with the Department of Mental Health about that. Communities of Hope is really doing the same kind of work that we're doing with the entire spectrum, not just children. This project really focuses on children, but we look for opportunities to bring all these things together. And the question is so appropriate because the left hand often doesn't know what the right hand is doing. And any opportunity we would have to converge things, bring things together, is we should look for those. Because people are, they only have limited resources, time and energy to spend on this. And so if you can bring those problems together, and they're so closely related to one another that they absolutely should be, then we should do that. Where did you, was it Moberly that you were mentioned?
Moberly was one of the SMBF funded communities.
Okay.
They're finished now, but they had 5 years of
Yeah.
prevention money from
Yeah.
the department.
There are, I believe, Community of Hope projects that are going on in these regions where we're at, and we're going to try and connect with them. Danny?
Yeah, Bruce. Rolla, Joplin, and Moberly are all very rural communities.
Yes.
Did you make a deliberate decision to reach out to rural Missouri and avoid St. Louis and Kansas City?
Yes, and the reason for that, and I think it could be questioned, but our reasoning was that we wanted a manageable size, because what we're after here is proof of concept, and we wanted to load the dice in favor as much as possible of success. So we had communities that applied to participate with us that had more need and much less infrastructure. And so you could make an argument and say, well, we should go where there's the greatest need. But what we were trying to do is figure out whether if you can put these resources into a community that has some of the infrastructure, whether or not it would work and we could actually have an impact. And so we thought that rural communities, apart from being neglected in general by a lot of these kinds of efforts, actually gave us the best opportunity. We also, as I said earlier, piggybacked on CBCAP, on the Children's Trust Fund, and these were the communities where they had been operating. And so, once again, we were trying to load the dice as much as we could in favor of success. We didn't choose communities that already had it all together. I don't know of any anyway, but we chose communities that were sort of in the middle and small enough and accessible enough so that we could get our arms around it.
Thank you. And the training academies, I assume that they were taught by run by the Bright Future staff, and that they were parents participating by and large, or community leaders?
No. The training academy was really staff. The faculty for training academy was really people who had expertise in these different areas of public health and bright futures. And one of our key consultants and the person who has helped us run those training academies, and she's also a longtime consultant for us, is Ellen Kagan from Georgetown. And Ellen has actually been working with the state team almost from inception, and is a recognized expert in that area nationally.
And the Georgetown program is just tremendously respected nationally, internationally.
Right.
And I was wondering about access to the KIM data. Could people use the KIM data set for theses and dissertations?
We contract with KIM to set up these sites for our communities. I believe that there might be a public access version of KIM so that you can do some things. You may have limited functionality, but I would encourage people who are interested to contact Dr. Chris Fulcher with the University of Missouri and Columbia.
All right, another question came in. Among community stakeholders, is there participation by congregations from the faith community?
In some communities, there are the beginnings of that participation. Part of the problem is giving them meaningful work to do, so we're still in that evolutionary stage where the teams, the core teams, are still trying to define who they are and what they're doing, and so they're bringing in, they're trying to bring in county commissioners, the faith community, the sheriff's department, schools, but in order for stakeholders like that to participate, they have to see value for themselves. They are busy people, and to come to another meeting it's a challenge, and so they really have to see value and meaning. So we have the beginnings. I believe in Moberly the faith community is represented with their team, but it's not everywhere.
All right, well, I think that's going to wrap up today's presentation. Bruce, thank you so much for your time today. Folks, thanks for joining us today from around the country. If you are still interested in CEUs, we'll leave the CEU application link alive for you for a little while, plus we'll send it to you in a follow-up email, as well as a link to Bruce's slides as a PDF. They can't edit them that way, so to keep them intact that way, but you can download them and use them to reference later on. Keep watching our website at mimhtraining.com. We've got a lot of programs coming up still. We've got our cooperation with the National Association of Social Workers Missouri chapter, and so there's programs listed up there under that banner as well. So if you or anybody else would like to join our email list, please do so. Our primary way of contacting people these days is through email. Saves a lot of money on the budget there to do it that way rather than doing it through the U.S. Postal Service, unfortunately. But that's how we live today, and so we're taking advantage of that a lot. So again, thank you for your time, and Bruce, thanks for yours.
My pleasure.